Hi everyone. We're presenting case 10.5 today, and it's all about non-fluent aphasia with right face and arm weakness. I'm Emily.
I'm Isabella.
And I'm Autumn.
So, our patient is a 45-year-old man who presented to the emergency department with right-sided facial weakness, right arm weakness, and an inability to speak. His medical history included several significant stroke risk factors, including hypertension, cigarette smoking, and chronic alcohol use. Hypertension damages the walls of blood vessels over time. Smoking accelerates atherosclerosis and increases clot formation, and chronic alcohol use can contribute to hypertension and other cardiovascular disease, all of which increase the risk of ischemic stroke. According to the case, he ate breakfast at the same diner every morning but had not been seen for 2 days. And when he returned, he appeared confused, was grunting incoherently, collapsed to the floor, and was unable to move his right arm normally. The restaurant manager immediately recognized that something was wrong and activated EMS. On arrival to the emergency department, his blood pressure was very high and it was 218 over 116, which indicated severe uncontrolled hypertension. At this point, clinicians were concerned about an acute ischemic stroke because of the sudden onset of neurological deficits combined with multiple vascular risk factors, and the neurological examination then helped determine exactly which parts of the nervous system were affected. So, the neurological examination revealed a very characteristic pattern of deficits. The motor testing demonstrated right lower facial weakness with forehead sparing, profound weakness on the right arm, and only mild weakness on the right leg. This distribution is important because it immediately suggests an upper motor neuron lesion affecting the left cerebral hemisphere. Language testing was equally informative. Initially, the patient presented with global aphasia, meaning both expressive and receptive language was severely impaired. However, over the next several days, his language evolved into Broca's aphasia. This improvement is likely due to the recovery of the ischemic penumbra, which is an area of brain tissue surrounding the infarct that had reduced blood flow but is still viable. And as the blood flow stabilizes and edema decrease, neuronal function can return, which leaves the more permanent deficit of Broca's aphasia. His reflexes were graded as 3 plus throughout, indicating hyperreflexia, another sign of upper motor neuron involvement. This occurs because damage to upper motor neurons removes descending inhibitory input to the spinal reflex arc, resulting in exaggerated reflexes. Although acute strokes do not always produce marked spasticity immediately, hyperreflexia supports damage to the corticospinal tract. And all of these findings strongly suggested involvement of the dominant left frontal lobe. This patient's pattern of weakness can be explained by the organization of the primary motor cortex in the cortical spinal tract. Beginning with the motor homunculus, the face and upper extremity are represented along the lateral portion of the precentral gyrus, while the leg is represented more medially because the lesion primarily involved the lateral motor cortex. The patient develops severe weakness of the face and arm, but only mild weakness of the leg. Um, Only the lower right face is weak while the forehead is spared, which is because the upper facial muscles receive bilateral cortical innervation, and the lower facial muscles are primarily controlled by the contralateral motor cortex. Um, this pattern is typical for an upper motor neuron lesion, and the cortical spinal tract also explains why the weakness occurs on the opposite side of the body. The motor fibers originate in the left primary motor cortex, descend through the brainstem, cross at the pyramidal decussation in the medulla, and continue to the right side of the spinal cord. The lesion occurs above the decussation, so weakness appears on the right side of the body. Combining the motor findings with the patient's Broca's aphasia localizes the lesion to the left lateral precentral gyrus within the superior division territory of the left middle cerebral artery.
Okay, so just for some like clinical terminology and everything, we kind of looked at posturing, and posturing has to do with abnormal body positions, and they occur in unconscious patients or patients with brain injuries, which makes it relevant for this case study. And there's two different kinds of posturing. We have flexor posturing and extensor posturing. And so we actually did not notice any posturing within this patient. We saw that there was right arm flexion when there was a painful stimulus, and this kind of is to be expected as a normal withdrawal reflex. So that's why we wouldn't really consider it typical flexor posturing. And because we don't have any posturing, we can rule out a brainstem lesion, which helps us localize the lesion. And then another just kind of term to know is triple flexion. And this is involuntary flexion of the ankle, knee, and hip produced by like some kind of painful stimulus to the bottom of the foot. And again, this wasn't tested on this patient because it said that he had volitional movement of his right leg, even though it was weak and he couldn't do it against resistance. But having that voluntary movement suggested that there was no positive for the triple flexion test. And when you do have an exaggerated flexion of the ankle, knee, and hip, that indicates a potential upper motor neuron lesion. And then over here, there's kind of some pictures of what posturing and then what triple flexion looks like. And then Isabella kind of mentioned this already, but the deep tendon reflex is something that we tested, and it was 3+ for all of his joints. And typical is 2. It's on a scale of 1 to 4. And then they saw contralateral weakness in this patient, which essentially is left motor cortex controls the right side of the body, which would explain the right lower face weakness and the right arm and leg weakness as well. And then for lesion localization, just with all this information, we are like starting to gather that this was a left precentral gyrus lesion in the primary motor cortex, affecting Broca's area and in the left frontal lobe. And then as far as Broca's aphasia and language vascular territories go, we noted that there was likely damage to the superior division of the left middle cerebral artery, and this would explain the expressive non-fluent aphasia or Broca's aphasia. So this patient had intact comprehension, but halting and word-finding difficulties. And then there would appear to be no damage to the inferior division of the left MCA because that would be more consistent with like Wernicke's aphasia. And then there was also no observed watershed territory infarcts. And so if you look here on all of these different pictures, the yellow area is where the middle cerebral artery kind of plays a role in the brain. And so there's Broca's area. It was all with the left middle cerebral artery.
Okay, so the MRI images show a large infarct involving the superior division of the left middle cerebral artery. The highlighted region represents edema and tissue injury within the affected vascular territory, and this infarct involves the lateral frontal cortex, including Broca's area, and the face and arm regions of the primary motor cortex. The superior division of the left MCA supplies Broca's area, as well as the lateral precentral gyrus, and because both of these functional regions share the same arterial supply, a superior division MCA infarct can simultaneously produce non-fluent aphasia, also known as Broca's aphasia and contralateral face and arm weakness.
All right, so just to talk a little bit about the stroke, how they treated it, their diagnosis process. On arrival, they did do a head CT, which was positive for a superior left MCA infarct, as you can see. Just a note, the top image is a more inferior view, so a lower view of the brain, a lower cut, and then B is a superior view, so a higher cut of the brain. As you can see, there's a pretty big infarct there. The infarct was 24 hours old, so the patient was not a TPA candidate. They did a full embolic workup where they had to figure out, was it a carotid occlusion or a just tight stenosis? An occlusion is a total blockage with no flow, meaning there was no blood flow to the affected area. Stenosis is a narrowing of the artery due to wall thickening, stiffening, plaques. It's that physical result of diseases discussed in class, like arteriosclerosis or atherosclerosis. So they did a carotid Doppler study, which is just a test that tests blood through the neck through imaging. And they also did a MRA, which is magnetic resonance angiography. Those both confirmed it was an occlusion, so a blockage, which helped confirm an ischemic stroke. Obviously, head CT was positive for ischemic, not a bleed, but that further concluded that it was ischemic and a total occlusion. Which brings us to our diagnosis, which is an occlusion of the left internal carotid artery by an embolus causing an ischemic stroke in the superior left MCA. Treatment for this was an aspirin or over-the-counter blood thinner, as they were not a TPA candidate. A statin, which is a cholesterol medication, removing the bad cholesterol, clearing those plaques away, and obviously lifestyle changes. And then I just wanted to zoom in on the anatomy. In this first image, I have the left internal carotid, which is where the embolus probably traveled up, which is connected to this yellow highlighted area of the brain of the second image, which is the MCA, which is where our stroke occurred. And then the third image over is just highlighting the Broca's area, so we are clear on where that is. And then I did want to note that there's a slight visible midline shift, and as Isabella was pointing out, there is some tissue damage, necrotic tissue, and also some water visible from the stroke damage. So our final diagnosis was that occlusion of the left internal carotid caused by an embolus, resulting in an ischemic stroke in the superior left MCA and Broca's aphasia. The outcome of this was much needed rehab and treatment. This patient was in the hospital for at least 6 days inpatient. Ultimately, the symptoms were getting better. They were progressing, but they were not at typical levels in the right arm and hand, and the aphasia was still very much present. These are her references.
Awesome. Thank you.